Good afternoon, everyone, and welcome back to another session of Tech Uncensored. My name is Sami Hussein, and today we're going to talk about the healthcare system. Is it broken? We don't know. There are a lot of conflicting messages out there, but I've got the right person to talk to today. I've got Dr. Rishad Usmani, an urgent care physician, an entrepreneur, and an angel investor. Thank you, Rishad, for coming on the show.
It's great to be here, Sammy, and excited for this conversation.
Yeah, so I'm going to just give you an example of, I'm going to talk about what happened to a personal experience, right? I mean, I grew up in St. Catharines, a small town, and I had two doctors my entire career. And the only reason I got the second family doctor is because the other one retired. And it was a very personal relationship. The doctors spent time with you, they got to know you, they know your whole family. And now we fast forward to today. Doctors don't want to get to know you anymore. It's like you're going through this. It's a numbers game. You just got to keep going. And there's everyone's going through there, and they want to get as many patients through. You feel like, where's the personal aspect gone to it? Where has the healer gone? It's such a noble profession, and I just feel some of that has been lost, right? And in the long wait times for specialists, I had to go see a specialist myself for my asthma, and it took 8 months. So I'm going to turn it over to you. Is it broken? Am I wrong in what I'm saying? Or
Yeah, I think that there's a lot to unpack there. I'll start by saying no system is broken. It's perfectly designed to produce the results it's producing. And that's a quote from Quality Improvement from Don Berwick. Medicine and medical knowledge doubles every 5 years. So if you think about it, we have to know about 12 times more what we had to know 20 years ago.
okay,
Yeah. Are you
yeah,
getting interference as well?
yeah. I'm gonna just mute myself, Rashad, because my fan is uh,
Okay,
going on. Hang on here.
sure. Yeah, so the amount of knowledge we have to know has grown exponentially over the past 20 years. That coupled with the administrative workload and burden, electronic medical records, more insurance paperwork, the way our notes are supposed to be now, has added quite a bit more on our plates in terms of the amount of work hours needed. There's a recent study out, we need 26 hours in a day to take care of the patients that we currently take care of with the same volumes. So obviously we can work 26 hours a day. And I think that's why we're seeing a shift in physicians practicing in an environment which prioritizes volume, and the reimbursement structure encourages that. The way we are rewarded financially in medicine is by seeing more and more people. And we get paid per consult. We make about $25 per consult after overhead. If you think about it, given our training and our opportunity cost, that's not a whole lot. And that's why people are seeing 40, 50 people a day. So I'll stop there. So, I mean, I hope that provides a bit of context why this is happening. I'll add one more thing. Most issues are system issues, they're not individual issues. And we should look at systemic changes like changing the reimbursement structure, changing our the amount of patients we take on over a year, um, to look at improving the system. And I do agree with a lot of what's being said in terms of team-based care with physicians as managers of teams is likely the future. But again, the reimbursement structure, the decision-making structure, and the liability structure all have to follow in accordance to that.
So that's interesting. I'm glad you said that. That there's you spend so much time on paperwork, and that would not have occurred to me. I would have thought that there's an admin. I don't know why, but an admin person in the background doing that for you. But so then, what's the? I guess $25. I agree with $25 just does not make sense, particularly the amount of investment, and you know, very few can go to medical school. Let's face it. So it's a very it should be a rewarded area as well. So what's the solution to that?
I think when you dig deeper into problems in healthcare, you always land on reimbursement. Prevention is cheaper. To give you an example, for lung cancer, delayed diagnosis and treatment is about $250,000, and early diagnosis and treatment is about a couple thousand. So there's a big gap between the cost of treatment and the cost of prevention. The problem is you don't realize those savings for years down the line. So if we live healthier lifestyles, if we don't smoke, we're not getting lung cancer, or if we do smoke, till well into our 60s and 70s.
Yeah.
And given the way funding flows, and given the time span of when organizations, government, insurance payers want to save costs, it's hard to design a system which incentivizes prevention, showing the financial ROI will not be captured for 40 years. So I think if we can solve that problem, everything else will fall into place in terms of incentivizing prevention. We'll have more physicians working in primary care. We'll have more remote monitoring softwares telling us, are you getting good sleeps? Are you eating well? Are you walking enough? And then providing the appropriate positive reinforcements to encourage healthy behaviors. There's a lot to unpack there. The immediate solution that is being proposed is expediting licensure for IMGs, international medical graduates, people who graduated abroad. I think that's a noble thing, and I think that's needed, but it's a band aid. If you look at the per capita of physicians in Canada, it's not too bad. We have 1.2 family physicians per thousand patients. The problem is more than half of them are not working in outpatient longitudinal settings. Now, if we expedite the licensure for these IMGs, I can't hear you, Sam.
What does that mean, outpatient longitudinal settings?
So what you described, like
Oh,
having a family doctor, what we call cradle to grave care. So
okay.
from your baby to your end days,
Okay. Okay.
um, we're not practicing in that setting because the reimbursement model doesn't encourage it. So you can throw in as many physicians as you want. They're still not going to choose that setting. And some of them might, but I think it's a band-aid solution that's going to last a few years. And unless you just want to do this cyclical care where you just keep bringing in IMGs, and again, obviously I'm an immigrant myself. I'm a proponent of immigration. I think we need a way to do it, but it won't fix the lack of this people not having a family doctor. Um, yeah.
What about so what if fixing this means that what giving doctors an opportunity to see as, let's say, a, a kind of a benchmark about how many patients you see and paying them a flat salary? Was that the solution?
Yeah. So I think value-based care, where value is
Yeah.
measured by the processes family doctors have in place and not only the outcomes, is the answer. If you place the value on the outcome, so say weight loss is a perfect example for this. If you incentivize people for a strict BMI, they will starve themselves. What you want to incentivize is a good diet and exercise. So
Yeah.
if you take that analogy to healthcare, you want family doctors to be available to their patients and to just provide the access to care that the patients need. The way to do it is our census, I think, should be around 500 patients. Right now, it's routinely anywhere from 1,500 to 2,000.
Wow.
Um,
Okay.
and as that, what happens is because the census is so much, we can provide good care because there's just too many people to provide care to. We don't feel good about ourselves. This is not to like play the victim, so to say,
Yeah.
but that leads to more burnout, and then we work less.
Yeah.
And we there's so many physicians trying to find ways out of clinical medicine because they're not finding clinical medicine sustainable in the way it's designed right now. So yeah, I think a team-based care, and it's okay for us to have 2,000 patients if we can hire nurse practitioners, physician assistants, even clinical assistants who are IMGs, um, to facilitate our the care provider. Right now, as it stands, is we can hire nurse practitioners, but we can't bill for them. So essentially, we can't hire them. We still have to see every patient. So I think um, if they could just change that we could bill for nurse practitioners, it would open up a lot of doors for a lot more people to get family medicine care. Now, the caveat there is if we do it for family doctors and specialists, again, specialists get paid more. The nurse practitioners will go the specialty route. The key is to increase the value of family medicine, both from a societal perspective, but also a financial perspective compared to specialists. And this is a sticking point where I think not a lot of people will agree with me.
Okay, yeah. So yeah, because specialists presumably make what, a lot more or significantly more or
Yeah,
market.
so in an urgent care setting, an internist would bill $84 after 30% would take home, um,
Yeah,
$55, $50,
yeah,
whereas I'm taking home $25 after overhead. It's a double
yeah. Okay,
for providing the exact same service.
okay.
And part of that is they have more training. So they do 2 more years of training, which is now they're extending family medicine residency for 3 years, which is another thing I don't agree with because if I can train 1 more year, and we've already trained 12 years at this point.
Yeah,
So if I can train 13 years instead of 12 and make double per patient, why wouldn't I do that?
yeah. Of course, of
It
course.
doesn't make sense to train the lesser amount.
Yeah.
Yeah.
So if it went to this model though, then you would require more doctors, would you not? Because you'd be seeing fewer patients.
Yeah.
It would be a more holistic way and more going back to the roots of why you went into medicine, presumably, right? So you would require more doctors into the system. Then we would have a shortage, would we not?
No, because if the majority of doctors took on 2,000 patients, say 50% of us took on 2,000 patients and had nurse practitioners, PAs, we would cover the whole population. As I said earlier in this podcast, the ratio is 1.2 family doctors per 1,000 patients. So if zero point 0.6 of us took on 2,000 patients, that works out to we cover the whole population. The problem isn't the exact number. Now, with an aging population, you can say as family doctors retire and physicians retire, and our population grows, there will be a shortage. But if you take a snapshot in time right now, uh, the problem isn't necessarily the number of doctors. It's more how they're practicing, how many people they're taking care of, because the work is not sustainable. Um,
Okay. And is that why doctors are not uh, locating to more rural areas where perhaps you're not going to be able to see the number of patients? And I mean, uh, the studies show that the health issues there are far more acute in less affluent areas than they are in affluent areas. I
yeah,
mean, that's a different problem, but how is that being addressed?
the problem with the rural area is in some places you only need one doctor to take care of the populations. If you lose that doctor, you have no doctor.
Yeah.
If you look at the percent or the numbers of people who don't have a family doctor, it's the same. And I think the rural area population is more societal or where people want to live. Generally, the rural areas, like practicing in rural medicine way more than urban medicine. Um, the medicine itself, the science and the cases you see is just more rewarding. And you do get a bonus in BC. It's up to 30% on top of what you make. In Ontario, the bonus isn't as much, but they give you stipends, they give you incentive bonuses, and some of the places are giving you 100,000, 150,000 over 4 years, which is a decent amount. Um, but I think that is more to do with just some people are city people, some people are rural people. Yeah.
So then, what is the what? So from a specialist perspective, what is the why is there long wait times there? Certainly, surely they're not seeing the same amount of patients.
Yeah, so it depends on the specialist. So we can talk about psychiatrists, and I know a little bit about this. For my startup, I hired psychiatrists. I looked into this. The ratio of psychiatrists to the population in Ontario is 1 to 7,800. Which is an okay ratio. The ratio it should be is between 7,500 to 10,000 to one psychiatrist. But again, less than half of them are practicing in outpatient settings. A lot of them are working for hospitals, but also a substantial amount are working for private insurance companies. You get paid better, you have better lifestyle, better work life balance, which is different from surgical specialists, in which there is a overabundance of specialists, but there aren't enough jobs in Canada. Um, Plastic surgery, orthopedic surgery are a couple examples here where the OR times are so restricted, partly because of politics, partly because of nursing staff, that the specialists don't have jobs. And I can talk about I did my residency in Campbell River, which is a town on Vancouver Island. Beautiful place. It's called Salmon Capital of the World. But, small town, like 25, 30,000 people. They posted an opening for a plastic surgeon, and they got 10 responses in 2 days. And these were people who are Harvard, Yale trained, wanting to work in Campbell River, which is not to like harp on Campbell River. It's a beautiful place, and UBC is a great school. But you wouldn't expect that. You wouldn't expect that there would be an abundance of specialists, plastic surgeons who have trained 5 years of residency, sometimes have done subspecialties, wanting to go to Campbell River because there are no jobs.
Well, that's it.
Um,
That's sad to hear, actually. That is very sad to hear. But what about the ones that there are, like for instance, for me, when I had to go see my respirologist, or
yeah.
for my mother, who has been waiting 8 months for cataract surgery. So that hasn't happened. In fact, she told me last week she's been booked. She's going to cataract surgery. And then my sister called me and said, no, she's going in for a consult. And hasn't been booked yet.
So, I mean, I'll quote a colleague, Mike Warner. He did a great video on this and how all our ORs close at 4 p.m. and they're not open on weekends. So if you could just open the OR, because especially they want to operate, they're surgeons, like they like operating. That's what they train for, such sometimes 17, 18 years total. Is as they don't have the ability or the OR or the operating room available to them to operate. I think that's the easiest fix. The other answer I would give is because specialists don't have jobs, they leave. They go south of the border. They establish their lives there. And once someone is settled, you have kids. It's hard to move once you're settled and your kids are settled in. Like my daughter's daycare is down the road. Like, I have to have a really strong incentive to move at this point.
Okay. So let's talk about what is Ford doing. He wants to privatize. There's some disrupting technology that's coming out where they're doing online healthcare.
Yeah.
Are these models sustainable? What is? I don't understand what Ford's plan is, because he says he's privatizing, yet he's saying, don't worry, the system will still cover it. Well, how is that different than now? And then the online healthcare, why would the problem go away?
Yeah, so I'll speak to both issues. For the privatization, our healthcare is publicly funded, but the vast majority is privately delivered. We have more privately delivered healthcare than the states. So in some sense, we're more private than the states. Although the funding is where usually when people say private care, they mean private funding, not private delivery. What private delivery means is you could open a hospital, and we have lots of hospitals like Mount Sinai, which are private hospitals. But you build the government, and you're not allowed to build the patient directly. So what he's doing is essentially saying you can open your hospital and build the government. The main problem people have with that is, well, where will the staff come from? But if there are surgeons who are looking for operating room and the current hospitals are not providing it, then yeah, they will go to these private centers. Now, a much easier solution is just to open the public hospital ORs for a longer time frame, so you don't have to build a new facility and fund it and the waste more taxpayers' money. For online care, we had these codes we were billing in COVID, billing codes for OHIP. So how billing works is when you go see a doctor, we bill the government and then they pay us. Before COVID, we didn't have virtual billing codes outside of a specific network called OTN. But during COVID, they opened these codes as I could just call a patient and I could bill. And I could bill the same amount I would get as opposed to in person. So this led to some abuse from family doctors, where they would just bill 80 consults a day, and you can't do 80, and they would do them, but they would just cut them really short. The billing is based on an honor system. The audits are kind of they're frequent, but they're but like if you're a high biller, and then they'll kind of go audit you. Um, what happened with this is I think I don't know why they made this decision, but they cut the billing codes to about a third of what they paid previously. So now essentially online care in the public system doesn't exist because from my perspective, it takes the same amount of time, aptitude, mental energy to do a phone call with a patient as opposed to see them in person. If anything, I'm much faster in person because I can examine you. If you come in and you're saying, my belly hurts or my throat hurts, I can look. Whereas if you're on the phone, I have to ask you a lot of questions and maybe have to ask you to push on your belly on different spots. It takes longer almost to do a phone consult than an in person in some instances. So what a lot of physicians are saying is they're not offering phone care, and they're saying, we can provide better care in person, and we will just do that. So now inadvertently the access to online or and I think this is terrible for rural communities specifically, uh, because they're the ones most affected. When I ran my telemedicine company, a lot of my patients were from rural, and they were very thankful because if I wasn't there, or if the one of the physicians we hired or employed weren't there, they would have to drive an hour or two to the next clinic. Um, yeah,
I mean, so that's a good point. So there is a role for telemedicine. It's just that there's also a danger of being abused. I certainly have seen it myself, where you know my doctor would call me for a 2 minute call and then go to the next call, go to the next call. I mean, I'm just saying, how are you going to do a physical on the phone with me?
yeah,
Seriously, it just becomes then you. I mean, there are people who are just going to believe it, but there are people like me who are going, okay, this is just being abused, right?
yeah.
So,
I
and
think
then
that
there are people like you who are offering real value and services, and as a result of these outliers, it gets cut.
yeah,
So you think there's no the root of telemedicine, and we see tech startups that are doing this telemedicine
yeah.
area. You think that it's not viable?
No, I think there's definitely a digital first home based care model as it would be an amazing innovative process. It would allow people to get care in their homes. When you're sick, you don't want to go to a clinic. You don't want to go to urgent care or an emerge or a hospital even. You want to stay home and be taken care of at home. We have the technology to do it. We have the medical knowledge to do it. It's simply we don't have the reimbursement structure to provide
Wow.
that care. I think that's the answer. I think we can screen better on the phone. Now the caveat there being some people will abuse it, and maybe there needs to be more monitoring or more structure around it, and say, if you're vomiting, right, come in, right.
Yeah,
Don't allow that code to be billed virtually.
yeah,
But if you need a refill on your blood pressure medication and you saw your doctor last month and I have all the information I need, then I don't need to see you. We can do it over the phone.
yeah.
Um, so I think that a digital first, home first care model, it should be the future. I don't know if it will be the future, but I think it should be.
Should be the future. Okay, well that's good to know. Then what about so you're saying in emergency rooms, uh, why are there long wait times? Why are there 22-hour wait times on average in
Yeah, I
emergency
mean, the biggest reason is lack of access to primary care. People are going to emergencies rooms when they don't need to. I think that's kind of the short and sweet answer there. Yeah.
But then, I mean, I know there's some outliers where people have died in the emergency room. I don't know if this was just a one-off. It was an error. It doesn't make sense because I would think that somehow these patients would get triaged. But
Yeah, I think there's a couple of things here in which the system is designed, and it goes back to about 20% of people admitted to the hospital don't need to be there, but they're there because there's nowhere for them to go. And that's because we don't have enough nursing homes, enough community home care infrastructure for those people to be discharged. And that follows downstream where people are admitted to the hospital, but still in emergencies room because there's no bed for them upstairs. There's no bed for them on the ward. And that goes further downstream is for an emerge physician to take care of a patient, they have to be in the emergency room. So if you're waiting in the triage bay or in the emerge, yeah, like a nurse will lay eyes on you once in a while. But unless you're coding or unless you get really sick, you're not gonna get continuous care because you're not on a bed. The other thing is the way our paramedic system works is paramedics have to take the patient off the stretcher onto the hospital bed before they leave, and they have to do a sign out. If the hospital doesn't have beds, then these paramedics are stuck as well, and they can't go out in the community and provide care. I think the again going back to incentivizing care at home would help here. I don't know enough about do we have enough emergencies room spots or capacity. Um, your intuitive guess would be we don't, but I can't comment on that with accurate numbers because I don't have that information on hand.
So I guess I mean the problems you're highlighting, I can see is it's almost a cascading effect. If you don't fix this here, it's just going to trickle all the way down the whole stream, the vertical stream here. But even the private model that's being suggested by the province of Ontario, um, the billing directly to the government. I mean, isn't that what we do now? Isn't that what doctors do now, anyways? So what's changed? I don't understand what's changed.
Yeah, nothing. I think it's um, they're
How does it make
allowing
it better?
it doesn't. It allows people to open more facilities. So you can open clinics and build a government, but as it stands right now, I cannot open a hospital and build a government. I need approval, or I can't open a surgical center and build a government. So now they're allowing more people to open surgical centers and build a government. Um, yeah, so in that sense, people will get more surgeries, but I think the problem I have with the system is if it's public funded, it should be public delivered, and care should be streamlined. When you get all this decentralization to an extent, but all this segregation of scattered care, then incentives aren't aligned, and it leads to more inefficiencies and misuse of and misappropriation of funds. I think a private system could work with the appropriate structures in place. And I like the Swiss system here, in which everyone is mandated to have health insurance, but you have to pay for it. If you can't pay for it, then the government will subsidize you. It does create some tiers of healthcare, so you can pay for faster access. Now, obviously, you can't pay for faster access if you're having a heart attack. Everyone who has a heart attack gets the same access. But say you have acne or something cosmetic, which again, not to pick on acne because it can have very real mental health effects. But say you have something that most people would agree, or your belly hurts when you eat once every week, something that is less or not as significant. People can pay for expedited care. So instead of being seen in a week, you could be seen today. That in some ways goes against the Canada Health Act. Now, the Canada Health Act only applies to physicians. It does not apply to nurse practitioners. It does not apply to pharmacists. It does not apply to physician assistants. So the way around that could be because I think changing the Canada Health Act or removing it is too big of a project at this point. Um, but yeah, I think a tiered system like that with rules in place saying that you can't expedite care for heart attacks. Everyone needs to get the same amount of same efficiency and speed of care delivery for something like that. That could work well here.
In a perfect world, or your solution, if you could go to Ford or to Trudeau and say, "This is what we need to do. These five things," what would they be?
So I think the Swiss system borrow from that, allow people to pay a little bit more for uh, more care in a structured manner, change the reimbursement for primary care, allow us to bill for nurse practitioners. I think just those, even if they just change the reimbursement for primary care and allow us, but only primary care to bill for nurse practitioners. Because what you want is more physicians to choose outpatient longitudinal primary care,
Okay. All right.
because and that will ensure that the 20% of Canadians who don't have family physicians get them. Uh,
Okay.
I'll keep it simple. Just do that one thing. Uh,
Okay. Well, Dr. Rishad Usmani, thank you so much for taking the time to chat with me at Tech Uncensored. As always, I will be in touch with you. But thanks and have a great weekend. I think we've got a snowstorm coming, so stay safe.
yeah, it's been a pleasure, Sam. It was great being on today.
Okay. Thanks a lot. Take care.
You too.
Bye bye. Bye bye.